Hi there everyone, this is part 3 of the lecture Acute Inflammation. My name is Dr. Mardiana Abdulaziz from the Department of Pathology, UITM. At the end of this part of the lecture, you should be able to describe the outcomes of acute inflammation and to describe the systemic effects of inflammation. There are several potential outcomes of an acute inflammation. So as you can see in this diagram here, first, whenever you get an injury, then you will get that acute inflammatory changes with the vascular changes and neutrophil recruitment and all the associated features and cardinal signs, etc. that comes with it. After the completion of inflammatory process and termination of that inflammation, then you can have any one of these potential outcomes. So number one, you could get complete resolution of that inflammation, and this is the most desirable outcome because it means that the tissue has gone back to normal, to its original state. So you want that to happen. But sometimes the acute inflammation can progress or persist and form a local abscess collection. Sometimes acute inflammation can progress to become a chronic inflammation, and occasionally acute inflammation can also heal in the form of fibrosis, and you can see the connection in between these outcomes. So they can directly go into complete resolution, they can progress into chronic inflammation, and they can also heal directly by fibrosis. And if the inflammation has gone to become chronic inflammation, then healing will be by fibrosis. And if acute inflammation has formed a local abscess, it will also heal by fibrosis. So there is that interconnecting sort of relationship between these outcomes. So what would favor complete resolution of an inflammation? This can happen if there is limited injury to the tissue, there is limited tissue destruction, if the injury occurs within tissues in which the cells have the capacity to regenerate. So these, you're talking about labile cells especially. If there is rapid removal of the causal agent, rapid removal of fluid and debris, this will also favor complete resolution. What about an abscess? So abscess occurs if there is extensive vascular permeability, so there'll be a lot of fluid and leukocytes and debris which comes out of the vessels, and also certain types of injuries such as infection by pyogenic bacteria, or if there is retained foreign body. These are factors that would favor abscess formation. In terms of chronic inflammation, if the insult persists, you can't remove the injurious agent, or if there is interference with normal healing process, then chronic inflammation may occur. And in terms of fibrosis, fibrosis will occur if there is substantial destruction or loss of architecture. This can be a direct effect of that acute inflammation, or if there is abscess formation tends to also damage the architecture. So if there is substantial destruction of the architecture, then healing will be by fibrosis. If the inflammation involves tissues which are incapable of regeneration or have minimal capability of regeneration, so in permanent tissues, in stable tissues, they do not have the same capacity to regenerate as per labile tissues would. So they also have the tendency to heal by fibrosis. And the third factor that would favor fibrosis if there is impact clearance of fibrin exudate. And we talked about this earlier in terms of the morphological patterns of acute inflammation. So if there is a lot of fibrin exudate which you cannot clear, then there will be a lot of granulation tissue and fibroblasts that come into that site, and therefore fibrosis will be more likely. So now let's look at the systemic effects of inflammation. As opposed to the cardinal signs of inflammation, which are local effects of inflammation, effects of cytokines can also lead to a more widespread systemic manifestations, or what we call systemic effects of inflammation. There are several main systemic effects of inflammation that you should know of, and these include fever. Second one, acute phase proteins production. The third one is leukocytosis, and the fourth are the constitutional symptoms and signs. And they all have their individual pathogenesis, which is summarized here. So for example, for fever is typically a result of infection. However, there are non-infective causes which may result in fever as well. Exogenous pyrogens, such as bacterial products, will stimulate prostaglandin synthesis, which in turn will stimulate production of neurotransmitters that will reset the temperature at higher set point in the hypothalamus. So that what leads to fever. In terms of an increased production of acute phase proteins, these acute phase proteins are produced or synthesized by the liver, and the examples include C-reactive protein or CRP, fibrinogen, and serum amyloid. And their synthesis is upregulated by cytokines. So the liver will produce more in the presence or stimulation by the cytokines. And fibrinogen in particular will cause the RBC to bind and form Rho-Low formation, which forms the basis of a high erythrocyte sedimentation rate, which is also one of the parameters of inflammation. The third manifestation is leukocytosis, which refers to an increase in the number of white cell count in the blood. The pathogenesis for leukocytosis, there are two of them. The first one is accelerated release from bone marrow. So in the setting of inflammation, the leukocytes from the pool within the bone marrow will be released quicker than normal, including perhaps some of the immature forms. So this accelerated release from the bone marrow will lead to leukocytosis. The second pathway or pathophysiology of the increase in leukocytosis is that in the setting of prolonged infection. Whenever there is prolonged infection, this can lead to proliferation of precursors in the bone marrow as a result of stimulation by colony stimulating factor. Other constitutional symptoms and signs, such as increase in pulse, increase in blood pressure, etc., these are all due to direct cytokine action on the brain cells. So let me just show you an overview of the systemic effects of inflammation and their pathophysiology using this diagram. So if you have a look here, we have an infection or some kind of stimulus to the inflammation, and this can act, if it's bacterial product, it will act as exogenous pyrogens, and that will stimulate leukocytes to release cytokines such as TNF, IL-1, IL-6, which now act as endogenous pyrogens, leading to increased activity of the COX enzymes, conversion of arachidonic acid to prostaglandins, and in the hypothalamus, these prostaglandins will stimulate production of neurotransmitters, and the temperature set point will be reset to a higher level. Then you get fever. Okay, and the same stimulus, because you now have release of cytokines from the leukocytes, these will affect the liver to increase synthesis of the acute phase proteins, and that leads to the high CRP, fibrinogen, serum amyloid, and high ESR. In terms of leukocytosis, again, the cytokines will accelerate release of leukocytes from the bone marrow. So that is one mechanism of leukocytosis. And on top of that, if there is a prolonged infection, there will be increased production of colony-stimulating factors, also resulting in increase in the production of white cells and subsequent leukocytosis. And there are some direct effects of the cytokines on brain cells, and TNF, for example, regulates energy balance and causes reduction in appetite, and that can lead to various manifestations. So to summarize part 3 of this lecture, we have discussed the potential outcomes of acute inflammation, in which you may get complete resolution of the injury, or it could progress to form a local abscess. It could progress to chronic inflammation, and it could also result in fibrosis. And there are several factors which will influence these outcomes. We also discussed about the systemic effects of inflammation, within which the main ones are fever, increased synthesis of acute phase proteins, leukocytosis, as well as various constitutional symptoms and signs. And we have also discussed their pathophysiology. So that wraps up our topic on acute inflammation. I hope you all enjoyed the presentation. Thank you.